Good morning, afternoon, and evening to all the panelists and attendees who have made the time to participate in this webinar to celebrate the World Health Day 2023. The theme for this year is Health for All, and an important contributor to realizing this theme is the community health worker. Today, the Rural Seeds Ambassador of the Wonka South Asia, or Warsaw, group are organizing this panel discussion on promoting health equity, approaches to improve the working conditions of community health workers in Southeast Asia region, in a joint initiative with Warsaw and the Prasanna School of Public Health. I would like to introduce Dr. Pratish Kumar. Dr. Pratish Kumar is a highly accomplished medical professional with a wealth of experience in family medicine. He is currently serving as the Secretary of Rural Wonka and Chair of Wonka Rural South Asia. Dr. Kumar has also been a member of Wonka Executive Board as a member at large from 2018 to 2021. He is the founder of Happy Project, which is aimed at improving healthcare outcomes for rural communities in India. With his extensive knowledge and expertise in the field, Dr. Kumar has been instrumental in driving significant improvements in healthcare delivery and promoting health equity in Southeast Asia. Dr. Kumar, I'd request you to kindly share a few words and we can start the panel discussion.
Thank you, Dr. Nachiket. So it's a great pleasure to welcome you all to this webinar by Rural Seeds. And as you all know, the Rural Seeds are one of the most active unit of our Rural Wonka with the World Organization of Family Doctors. And they have got lots of ambassadors spread all over the world. In different regions, we have got very active ambassadors who are doing some great projects, webinars, and trying to engage with different health professionals coming from different backgrounds. So rural Wonka is little different because we not only have family doctors on board, but we also have different health professionals like nursing, community health workers, physiotherapists, and it's an important platform because we take health very seriously, and rural health is all about teamwork, and teamwork really works. And I'm very happy to see all the panelists from South Asia region joining on this webinar. And we hope that together we can achieve universal health coverage. We need to influence our policymakers to take good decisions towards strengthening primary healthcare, not only in India but in South Asia and globally. And we have good models all over the world which we can share, and hopeful that all those who are listening or watching us can it will be important for them also to share the feedback and also to learn what important change makers are going to say. So thank you and welcome to this webinar.
Thank you, Dr. Pratish. I'll now introduce the panelists, Dr. Ramakrishna Prasad, a family medicine physician and educator. Dr. Prasad is a board certified in family medicine with expertise in infectious diseases and public health. He is the founder and director of PCMH Restore Health, a patient-centered medical home and incubation center for innovation, people building, and collaborative problem solving. He also practices as a senior consultant of the infectious diseases and family medicine at the Trustwell Hospital, Bangalore. Currently, he serves as the president of the Academy of Family Physicians of India and the AFPI chair for primary care research and policy. Additionally, through several public health leadership networks and through his close association as family medicine educator at Basic Health Services Rajasthan and as an external member of the Board of Studies of the Prasanna School of Public Health, Mahe Manipal, he works in particular to promote community-oriented primary care and capacity building, training, upskilling, and system strengthening of primary care teams, drawing on the principles of family medicine. Dr. Abdul Jalil Khan, HOD, Family Medicine, Khyber Medical University. Dr. Khan is a consultant family physician with over 17 years of experience of working in the NHS UK, Great Britain. He is the Fellow of Royal College of General Practitioners, Faculty of Public Health and Higher Education Academy. He has been awarded the NHS Leadership Academy Award in Healthcare Leadership and Management and the ILM Award in Strategic Leadership. He assisted the General Medical Council UK as an associate and was a PLAB examiner. He is also a specialist advisor for Care Quality Commission in the UK. He is currently working in the Faculty of Public Health, leading the Family Medicine Department at Khyber Medical University, and involved in training of primary care doctors for the WHO Bridging Program for family practice and its incorporation into the primary care. He is also a medical educationist and has been involved in developing curriculum for various clinical and non-clinical programs, including infection prevention control, healthcare quality, family medicine, diabetes management, palliative care, and other mental health courses. Dr. Beena Shrestha is the first female program director in 6 decades of Family Planning Association Nepal's history, is an obstetrician and gynecologist with public health expertise. In 22 years of the medical field, Dr. Beena has been continuously providing sexual and reproductive health services and technical support to working groups of various divisions and centers under the Department of Health Services in Nepal. Dr. Beena is a strong advocate for task shifting and sharing and access of quality service by all. Dr. Beena has worked with PSI Nepal as a senior clinical service manager and worked to increase the access to ensure availability and quality service by the community and worked with private sectors, including pharmacists and other stakeholders within the healthcare system. I would like to introduce Dr. Subhash Chandran Kumar. He is an academic and a family physician. His interests are in identification and management of patients with chronic disease in primary care, health system development, and health technology implementation in low and middle income countries. He is a research fellow from the Institute of Applied Health, University of Birmingham, and a co-investigator to an NIHR grant, NIHR Global Health Grant, along with Institute of Applied Health Universities of Birmingham, UK. He is also the co-investigator of the WHO-sponsored Primary Healthcare System case study. He is the coordinator for Center of Digital Epidemiology, Faculty of Medicine at University of Jaffna. He is the primary investigator for water and health needs in Ireland's a collaborative project with the University of Manchester. With this, may I now request Dr. Beena Shrestha to share her country example or a case study related to the role of community health workers and their working conditions. Dr. Beena, over to you. Thank you.
Thank you. Thank you so much for involving me in this very important topic. And thank you, everyone. Well, I would like to start. I am not going to share any case study, but I will just introduce on how Nepal started this FCSB. We call it FCSB, the Female Health Volunteer Community Volunteers. So this female community health volunteers at the program was established because the for the maternal and child health improvement. So with that background, Nepal from 1989 90, this female community health volunteers had been envisioned for the to promote the health services in the at the community level. So the objective of this program was to activate the women for tackling the health problems by impairing the relevant knowledges and skills. So, and in that regards, like they have prepared to prepare the pool of self-motivated volunteers as a local person for bridging the health problems with community, to prepare a pool of volunteers to provide the services to the community-based health programs, to increase the participation of the community in improving health, and to also to develop the FCSB as a motivator for the health. So to increase the utilization of healthcare services through the demand creation was also the objectives while introducing this program. So the in our country, the role of the FCSB is to concentrate on the health promotional activities of the mothers and children in their working areas. Besides that, now every program, every national campaign is start is when we talk about every campaign, the first thing comes in our everyone's mind is FCSB. So they also helps in promoting utilization of available health services and raises the awareness on health through the mother groups of health also. So FCSB will help in various health programs, like family planning, safe motherhood, newborn care, immunization, nutrition, communicable and epidemic diseases, acute respiratory diseases, diarrheal disease control, environmental sanitation, health education, and other national programs. FCSB provides recommended service like drug distribution and disease management as directed by the Nepal government based on the community-based approach. Even the distribution of the family planning method like a resupply of the oral contraceptive pills and condom is gone through the FCSB. Other health programs also might improve are the FCSB through their guidelines. However, the involvement of the FCSB in other programs should be mandatorily endorsed by the central level FCSB coordination subcommittee. So they also has to annual report to local health institute and to the mothers groups in their community also. So FCSB also has to submit a monthly report of their activities to the local health workers or the supervisors every month. And FCSB can all these are the area that have to do, and we have around 52,000 FCSB in country. This depends upon the population, basically population in and the geographical region. So in Tarai region, per thousand population, one FCSB. So in that ratio, FCSB is formed, and in the in the hilly area, it is around five 700. For in hilly areas, it is 600 for one, and in the Himalayan region, it is around for 150 population one. Sometimes with the geography or the some condition arises, local government have has authority to assign more FCSBs. So, how we select FCSB is this should be from the resident of the relevant ward of the BTCs, and they need to be interested to work as a FCB at least for 10 years. The age group is also limited between 25 to 45 years, and married or single, both is we can have a FCSB, but the priority is given to the women having children up to three. So, and they have to have a commitment to serve the community, and priority will be given to those who can read and write. And priority will be also given to the women from the Dalit, Janajati, and marginalized groups. Those who are interested to be FCSB will have to submit an application to mothers group of health at the community. From them, they will recommend the person. Then only they will be appointed by the local government. Uh, those who are in the paid job will not be allowed to be a FCSB. So it should be a voluntary, and the retirement age is 60 years. And so these are the things that our FCSB have a basic information. And the uh, right now, what we see in our country is each and every program like tuberculosis or HIV, or even during the pandemic, they had a very vital role to reach out to them. At present, like as we have a challenging sustainable development goals, for that also we maternal mortality, neonatal mortality, all this we have to reduce. So in that also FCSB is being mobilized for the awareness program, for information sharing, and also for the uh, institutional to increase the demand and for the to increase the institutional services also. In some part of our country, still institution delivery is very less, and maternal mortality ratio is also not up to the mark where we want to achieve by 2030. So it's very challenging, and we see that their role is very vital in this pandemic, in this economically stressful, whole world is stressed with the economic crisis. In that one, I think FCSB has a very vital role to reduce the out of pocket expenditure from the community. So awareness and preventive roles that we need to spread through the in the community is from the FCSB. So this is the situation of our FCSB. They have been tirelessly working. Sometimes when I take a program in the local level, I feel that without any certainty of the any payment, there are working, they are coming, working for hours to the health facilities or where we organize the program. And in Nepal, you know that beside the Tarai belt, all hilly regions and the mountainous area, it's very difficult zone to have transportation facilities. So in that situation also, even during the landslide or the vaccination programs, they are supporting us. So they are the key person, community that we really need to support and strengthen. And
Thank
if
you.
there is any other question, I'm ready to respond to that. Thank you.
Thank you. Thank you, Dr. Veena, for walking us through the journey of the FCHPs. Now, may I request Dr. Jalil Khan to walk us through his cases?
Thank you very much. As obviously the story is the same across South Asia. So what I heard from Bina was similar in Pakistan as well. And no wonder, like, they have a very important role. Um, I would like to ask my friends as well, like, I know you guys call it a community health workers, but in Pakistan, when it was started, it's most focused on ladies. So it's called lady health worker program, and most of them are female. And when it started, in 1990 to 1993. And initially, they kind of recruited around 110,000 of these lady health workers. And as Dr. Bina mentioned, yes, they were very vital, and especially in far-flung areas and difficult to access areas. And they've been working tirelessly since then. And, they've been involved in maternal health, they've been involved in child health, immunization, infectious diseases, and they're doing miracles. And we have even statistic from Pakistan that they've reduced the maternal mortality, they've reduced the infant mortality, they've improved the contraception uptake rate. They've certainly, and it's been documented, and it's been a lot of evidence is available. So the system, how it works in Pakistan is with every BHU and RHCs, we have around 20 to 25. It depends on the size of the BHU, around 10 to 20 or 20 to 25, if it's a rural health center, lady health supervisors. And then the supervisor, each supervisor have around 20 to 25 lady health workers working under them, under their supervision. And they're also linked with a district coordinator officer, which is most of the time a doctor. And each lady health worker then have assigned households, and around 1,500, but in some areas where there's lack of the LHWs, it could increase. And we have very good case studies recently. I did a consultancy with WHO after the floods on kind of training or health promotion regarding to the prevention of waterborne disease. And it was in a area, far-flung areas, were badly affected. And it include 3 districts in KP, which obviously it was a lot of districts, 12 districts or even more across Pakistan. But I was leading in KP, so I was assigned the district Sawat and district Diyai Khan and Tank. And I did a lot of training by myself, and I went to those areas, and I was surprised, to be honest, because most of my work experience was from UK, and I've only moved to Pakistan 3 years ago. And when I joined there, to be honest, I was not expecting that much, because here in UK we take things for granted. But when I did a session or a few sessions with these lady health workers, their job information, their job description, the way they had information about, health promotion on infection prevention was very good. And I was really impressed. And they were, as I said, like, mostly local women who belong to the community, who go to each houses. They even have a health house, one of their houses get declared as a health house, and women do come to them. And because it's issues like culturally and social acceptance, so if it's female, obviously they can easily go to the houses, and they're doing the miracles. So when I even calculate, I did some statistic by myself, like, so when we train around, say, 40 or 30 lady health supervisors, and then few lady health workers, but then it was a cascade training model. So the lady health supervisor then trained each of their 20 to 25 lady health workers, and that came across around 1,500 people, like, we trained. And those 1,500 people, so just imagine if they have 1,500 household, so the people who got benefit from them were like around 2 to 3 million. And I was surprised, like, because as a family physician, I feel like, I'm doing health promotion, health, and, each patient, so I can hardly see like 40, 50 people a day. And out of them, like, obviously 20, 30, I would, do health promotion and activity. And I was surprised. And then I was talking to the other people and saying, look, so now obviously we are doing medical camps, and, let the people have the waterborne disease, and then we go there and give, partial treatment, partial medication. And, these lady health workers, obviously they started this health promotion work, and asking them, like, to cover the water and cover the ponds, and how good they are, and, they're doing the disease prevention. uh, the only issues we come across, I'm not sure whether we have time later on or not, but, there are a few challenges which may be biased, like, dealing as being a family physician. I still feel like, there is lack of recognition and lack of supervision despite their hard work. Because in a way it's good, like, they are only even in Pakistan, they if they have done 8 years in school or 10 years in school, and they are allowed to become community health workers, and then they have extensive training for 2 years. The only problem is because when you have these 10 years of education, and, despite that you got a job, there is no career structure. They cannot be promoted. They cannot. I think hardly they can go to the LHS level. So I think, the way we did, like, in with nurses, like, that we had these registered nurses after matriculation, and then post RN we make them, if they get 2 years extra training, equal to in a graduation. So I think we need to start working some sort of thing, like, sort of training, so they can get recognized as being, once they've been graduated. Because I'm sure in even in Pakistan and other South Asian countries, people are getting more and more educated, and now bachelor is, quite common, and we can utilize, or, even upgrade their skills. And the only problem is because these posts are, when the time they were developed, the education rate was not that much, and we just put the bar at 8 years of a school or 10 years of school. But now we have a lot of people, like, who are graduated, or we have people, even the same people can, have 2 years of more training, and then, consider a better job perspective. The only thing I would say, in terms of supervision, they are normally supervised by a district health coordinator, who is a doctor, but he's not a practicing doctor. He's not a family physician. He's not a GP. He's an admin doctor. So I think, like, we once we promote the family medicine program, and, the family practice approach. So one of my friend, I think somebody just mentioned, like, about the teams. So I think that's what we need to do. So when we're developing the family practice model or family physician model, and we have a family physician led primary care, so then these services of these lady health workers will become more organized and more recognized, and they will be working under one umbrella, and they will be available to them all the time. The only last thing I would like to add would be the way they are doing the job with infectious diseases, with immunization, with maternal child health. Yes, they're doing a great job, and the only thing is it needs a bit more kind of integration, because they are all vertical programs in Pakistan. But I would also like to add, like, we need to involve them in non-communicable diseases as well now. And NCD, the way it's growing, the way, it's affecting now the communities in South Asia, I think it will be a very good resource. But hopefully, once we have this family practice approach model, and, a comprehensive family physician-led primary care model, and then once it's all integrated into it, and they have a better service structure, and I think they can do a better job, as the lady health workers or the health visitors are doing in developed countries. So I'm quite hopeful for that. Thank you very much.
Thank you, Dr. Jalil, for touching upon points such as their career progress and their education levels and the impact that they have created in Pakistan. So now let's move on to Dr. Ramkrishna Prasad. Dr.
Thank you. Thank you very much for the opportunity to speak. To take from where Dr. Jalil Khan has left, I want to re-emphasize that the working conditions of any person depends on several things, but three R's in particular. One is they must feel respected in the workplace. The second is there must be adequate remuneration which supports them in their roles and also makes their work um, something which supports their families. And thirdly, they must be recognized for their contributions and their efforts. Definitely, the community health worker programs, which have extended the reach of primary care within South Asia, have been a phenomenal success. But given our focus on promoting health equity, we have to look at the working conditions that we create for these remarkable individuals, most of whom are women, and the lengths to which they go in the service of the community. What I want to do is in the next 3-4 minutes, my I want to share where a lot of my learning has come from. My learnings have come primarily through my interactions over the years with community health workers, including ASHA workers in rural areas, mostly in India. I had the opportunity a few years back to be involved in a district wide training program for every Gram Panchayat. A Gram Panchayat is a village unit in one of the southern districts of Karnataka, the state in which I live and work. Um, and had the opportunity to train about 110 ASHA workers, Anganwadi workers, and also school teachers from each of these villages. And it gave me an opportunity to visit them, spend time with them, and also listen to their stories. This was in the context of COVID. There are a few things that come out, and I will share a few examples of some of the challenges related to their working conditions that came up. One of the ASHA workers, we had gone and we were speaking about anemia, and there were two ASHA workers who looked extremely pale, and I was with another physician, and this physician, who's a senior physician, he called one of the ASHA workers and said, "Can I look at your eye?" And he looked into her eye, and definitely her hemoglobin was very low. In fact, by clinical estimation, it would have looked like her hemoglobin was between 6 and 7. So something to keep in mind is as we look to utilize ASHA workers and community health workers as agents for improving health, we must not forget their own health. Number one. Number two, um, um, you know, when you look at how what the life or the daily life of an ASHA worker looks. So in this district, I met an ASHA worker, and there are two tiger reserves in this district. So these are forested areas, hilly areas, hard to reach areas, and there are tribal settlements. And this ASHA worker, all by herself, carrying a fairly heavy bag, walked through the sun and the rain for nearly 15 kilometers sometimes to reach a certain village to deliver services which of course deemed as essential, but you can also see the hardship they face on a daily basis. There has to be some thought as to how do we support the transportation, how do we support the safety of our community health workers. Thirdly, one of the challenges I have heard of is sometimes they say, we go to the community and people respect us because they see us as someone who's trying to be of help. But we are hamstrung by two things. Number one, we are also seen sometimes as the extension or the representative of the government. So if I'm upset, if I'm as a community member, if I'm upset with the services I'm getting from the village council or the government, local government, or whoever, or there are trust issues with the government, sometimes the person I abuse or I show my hostility to is the ASHA worker or the community health worker who is representing something larger and against which one feels powerless. The second is sometimes there is a tendency, Dr. Jalil brought this up very well, there's a tendency by administrators, district administrators, to utilize ASHA workers or community health workers primarily for data collection. This is not their necessarily their primary role. And what this does is it actually creates a trust deficit with the community, because communities, when someone comes and says, let me talk to you about your nutrition, let me talk to you about breastfeeding, let me see if you're getting immunized, people also expect services or solutions to reach them. But when you send someone as a part of your team who goes and collects data but isn't really empowered or doesn't have necessarily the tools to actually offer solutions, this can result in disengagement with communities. One last thing I will highlight is, so from some of the work that I did, I'll highlight two or three actual statements that ASHA workers gave, which gives you a sense of the complexity of feelings and context that they work in. For example, one of the ASHA workers reported, this was during COVID. And again, think about this. You know, when they were going home to home, crossing streams and mountains and hills and forests to far-flung areas, asking people to come for vaccination in a situation where there was very low trust in both the vaccine and many times in the efforts of agencies, and they had to face a lot of hostility, and ASHA workers sometimes had not been vaccinated themselves. So they were doing this, putting their own lives and the the health, their health and the health of their families at risk. One of them told me this story, which I found, or this example, which I found quite moving. So she said, people used to take food and other supplies from us, but used to decline signing the acknowledgement for receiving the supplies as they were wary and afraid of COVID related stigma and targeting. People assumed that we received rupees 1 lakh, which is 100,000 rupees, for every COVID positive patient that we helped admit to the hospital. And this misconception resulted in reduced cooperation. So sometimes they are the victims of misinformation or rumors and things like this. So I have given you a flavor of what sometimes the life of an ASHA worker is in terms of remuneration. Most states in India, to the best of my knowledge, an ASHA worker gets anywhere between 2,000 rupees and sometimes on the higher end 7,000 rupees. In many states, this money does not reach them on a monthly basis. There are sometimes delays of several months before they are paid anything. I also know of ASHA workers and community health workers. So community health workers, in my experience, work in two settings. One, they are associated with primary health centers managed or run by the government. Sometimes there are also community health worker roles at NGOs or not-for-profit organizations working in community health, but sometimes they actually live away from their family and continue to carry out their roles. So in summary, we have to look at the working conditions of community health workers through the lens of the individual, in terms of their workload, in terms of job security, in terms of financial remuneration, in terms of their own health status. We have to look at the working conditions or environment in the context of the community, how their work actually may hinder their own ability to function as mothers, which is a very important role in definitely South Asia. And what kind of community support they receive, what kind of peer support they receive, and we have to look at it in the through the lens of health systems, as in what are the organizational commitments we make towards them, Dr. Jalil again brought up the issue of supervision. Yes, supervision is required, as is recognition, but also the supervision has to be supportive. And I do believe that when the leader of a primary care team is a practicing family physician, that kind of supportive supervision is likely to be greater, because family physicians are less driven by targets, and more driven by a continuity of care related metrics. So I will stop at this point, but I'll be very happy to take questions about the different themes that I brought up. Thank you.
Thank you, Dr. Akya, for walking us through on trust deficit when it comes to healthcare workers going to the field and they being misused or mistermed as data collectors, right? So with this, we move on to Dr. Kumaran. Dr. Kumaran, could you please share your experience of working with community health workers or any case that you wanted to highlight?
Okay. Thanks everyone for the golden opportunity, and I really enjoy the experience the others share. So now come to our scenario. So I think we bit differ from the speakers. Thing is, we have come across things of over 30 years ago, and we are in a post-conflict area. So I just give some background of health system. The area now we are from northern province of Sri Lanka. They are divided into three medical officer of health services. So they are the functional units of primary health care service. So I am working in one of such units. So I am responsible for 55,000 population, and I am working in a place called Nallur in Baltic. But interestingly, even though we had this war, uh, we had a very good primary health care system. So we have very good antenatal care and pediatric care and vaccination coverage. So then our community health workers role here is, so we plan in a such a way to find where the gaps are there, where there is a challenge, find very difficult to face by the current primary care system. So we try to fill that gap or try to face the challenge by training the community health workers. So that is the idea behind it, right? So now how we are doing that? So now we divide our staff into portions, right? There's a planning and supervising a team, and there is an implementation team. So we have two teams involved in community health workers, right? So just take example in our Nallur team. So anyone who really interested to become a community health worker, they can reach the planning and supervising a team. The team is not in a local hospital. So the application will be taken off, and we will give priority for school drop girls. So that's the first priority, because I think, as you all know, that school drop and even the girls, they have many psychosocial. So we experience that training that school dropout girls will dual benefit, that the girls will give benefit to the community as well as our program will support to that. So once those people enrolled in our community health program, so we will allow the community health, newly enrolled community health workers to shadow our implementation team for about 2 weeks. So while they are shadowing our team, we do a SWOT analysis, weakness, opportunity, and the threat by our implementation team. So while after the SWOT analysis, our supervision and planning team will go through that, and we will direct our community health workers in one of the three pathways. So what are the three pathways? First, health service delivery. Second, medical education. Third, research. So we have three pathways for community health. Right. So then, according to your strength, weakness, opportunity, and threat, we will decide which pathway is better than. Right. If you take a health service delivery pathway, that divides into community and the institution-based care. So community-based care, then there are 6 programs. Simple: pediatric, adolescent, adult, pediatric, and women health and environment. These are 6 programs we already established in a community level that will be enriched by these community health workers. Likewise, in institution-based care, so we another 6 pillars. So we provide chronic illness care, OPD, and we produce minor surgical procedures, laboratory service, health informatics, and healthy lifestyle. So according to their strength, and they will be placed one of these programs. And second main pillar, medical education. That's of course 2 parts. One part is community health workers are tutors for the medical students and postgraduate doctors. They share their experience and work. That's one category. Second category, they can act as simulated patients. Nowadays, that is the trend. The OSCE exams and this mock exam, they act as the simulated patients. Right? And the third pathway for the research, so they may be as a member of a patient public involvement engagement forum in our university or community involvement engagement forum, or they can be a data collector. So these are the opportunities for the community health workers according their strength, weakness, opportunity, and strength. Right. So how we supervise their workers? Very simple. Because in each and every program, there are trained supervisors. They are the senior community health workers. So they are in the grassroots level implementing workers. So they will supervise the junior people, and the senior people give feedback to our teams. According to that, so we are providing on-the-job training. So in the training, their things will be improved. I train. Okay. So then, as Dr. Prasad mentioned, the 3 R's, and totally agree with that. That's very important. So all the staff, our university staff, health system staff, hospital staff, everyone has been thoroughly educated. They had to give equal respect and reputation for these community health workers. They also will be considered as part of the system. So that's training we have already given our staff, so they give that respect and reputation. Then the thing is how we pay the salary. As because of the economical crisis and various other political issues, the government not in a position to pay salary to community workers. So we approach a method called private-public partnership. So then we have many private and profit and non-profit organizations are ready to fund these community health workers. So then question is how? So then I can few examples I can show, right? Just for example, in the pediatric program. So pediatric, as I mentioned, in our system, they are very good. We have 99% vaccination coverage. So there are very good pediatric programs going on in our system. The main lack is the neurodevelopmental delay and disorders care, like autism and ADHD, now increasing in trend and prevalence point of view. So there is a system, a big lack in that part. So now our community health workers start to work on that. So then training, supervision, everything we look after. So how about the payment? So now we negotiate an NGO that's lodged in UK that's called Friends of Manify. That NGO ready to fund these trained community health workers who can provide the neurodevelopment. And another non-profitable hospitals in Jaffna called Green Hospital in Manipal, they have given that one building for this work. Now job done. So these community health workers now working in that particular hospital, there's a building, and that trust is paying that salary to them. So then the 3 R's covered. That is one scenario. Like another scenario, how we provide geriatric care. So now, as I mentioned earlier, because of the post-conflict, so the younger population, the percentage of younger population compared to older is very low. So then there's big problems in carrying the geriatric population. Again, we train another 10 community health workers to provide community-based geriatric care. Again, training, supervision, respect, reputation, okay. So the salary, again, we go for private-public partnership. So another NGO from that is called SJC87. So they provide the salary to these community health workers. Likewise, we start another program that's called Women Empowerment. So then there are women in the village. The women had a family economical problems and various domestic violence. So we start a program. So now we have trained another 6 girls to work on that program. So now we develop a proposal. So another NGO is ready to fund us. And when you come to the medical education part, when we develop grants, as I mentioned, we are involving in 3 big grants at this junction. So those grants, the patient public involvement engagement is mandatory. So then we can get the salary to these community health workers officially from this grant. So then patient public involvement engagement, community involvement engagement, these stuff has been taken. Simulator patient, yes, interesting. So all the simulator patient, there's allocation in our university to pay salary to them. So when they act as a simulated patient, they will be paid. So then service delivery, medical education. The final one is the research, right? So research, even I mentioned earlier, data collection and community involved engagement can be fixed. So I think this is the scenario. So every time when we deal with that, we write it as a case study and we publish these things in our local and regional journals. Last, I think 2022, we published our neurodevelopmental clinic in an Asia Pacific journal, and we have done many publications in the regional journals. So now we move to the next step that's called rural healthcare with the help of community health workers. Thanks.
Thank you. Thank you, Dr. Kumar. I have one question to all the panelists out here. So, how can technology be used to improve the working conditions of community health workers? And how can technology support in their efforts to achieve health equity? This is a 2-point question where the first point is around how can technology be used to enhance their working conditions, and second point is on how can technology enable them to achieve health equity. So please, the floor is yours.
Can I give a brief
Sure.
line on that? So a couple of things. Yes, technology can be used and should be used. The only issue is, like, when we talk about rural health and, rural, obviously hard to access areas, especially, in Pakistan, we always have like sort of internet issues and stuff. The only thing I would like to add, with the Dr. Prasad 3, because this was my famous Dr. Khan's 5 R's. So I added 2 more in that, was retention and results. So will you be able to retain them once you give them that respect recognition? And the same is for family physicians as well. And then they will give you the result, because we're having issue of retaining them as well. So yes, technology could be an issue, how we can retain them. So one is to bring the equity is like, because recently, like, we have a lot of blended learning programs for doctors and nurses. So we should sort of create some sort of blended learning for them as well. So while they're doing their job, because they are women who work in the community, who live in the community, who belongs to the community. So if we have sort of some sort of training, so their skills can be built up to a graduation, because they may be not easy for them to join, say, a nursing school or lady health workers schools in in main cities. So if we could develop sort of blended learning program, but with the program with having a recognition, so at the end they should get a certificate, a degree, which bring them at par, same level as other graduates. So for recognition, reward is not always the money. It could be like a sort of paper who give you that recognition, and once you have that recognition, automatically respect will come with that. So I think that will help in terms of equity, bringing them also in improving their work, because nowadays, even in far-flung areas, people do have access to mobile phones, do have access to smartphones. So if they have kind of been trained in IT, and then they will be able to send the messages out, because for tiny little messages, sometimes they have to go to each household, which now I'm obviously, it's not a replacement. I still want them to go and have that face-to-face and physical interaction with their patient and the community. But those who they know, like have a mobile phone or have a smartphone, and so they should be available. Plus, as this, like, telemedicine is now coming, so with them, if they have sort of some sort of applications. Also, I know we did discuss, like, that their job is not to collect data for others, but it is important, like, once they have been integrated into a primary care model and system, so then the notes they get is important. So they're doing a model in Islamabad, but again, Islamabad is the capital of Pakistan. It's a big city, and it's a modern city. But we can easily incorporate that into other, at least major cities. So the same can be done, across South Asia. So rather than them having a very long paperwork and they doing tick boxes and then retaining them, so they have developed. WHO is helping to develop an application for the lady health visitors and the lady health workers, which then obviously kind of they sorry that is mostly for lady health visitors, who are more kind of focusing on maternal and child health, but the same could be done for the lady health workers, and they should have these promotional tiny videos, which in the local languages they can have their information in written form, and if it's not available in written form, at these small videos they can then share it with the community. So yes, definitely have a role, and although they'll be, despite having challenges in the rural areas, I think as the networks of internet and mobiles are now spreading out to the rural areas, so I think we need to kind of update ourselves as well and update our lady health worker force. Thank you.
Thank you, Dr. Jalil. Dr. Beena?
Yeah, technology definitely has a very huge role, and for the cost minimization and all is still there. But for in case of our country, it's been only 5 years. We have changed the strategy of minimum qualification of the FCSB should be 10 grade pass recently only. So before that, and that is also mandatory only in the Tarai belt, plain belt. So in hilly and mountainous area, only those who can just read and write uh, can be appointed as a FCSB. So there is a National Health Research Council is doing one survey on the FCSB. After that results comes, I think I'll share that to this group also, like what is the condition of this one. Some of the area, like we do have access for the internet and the electricity, most of the Nepal, but still to have Android phones is a big challenge, and for the government also to distribute these also is a big challenge, and we do not have that much capacity of the health facility where the health worker will provide them those kind of training, and these are limited only through the some of the support donor agencies support and all. So yes, definitely the technology is a big breakthrough to minimize the cost and to bring the system in place, strengthen our health system. But still, the it's not that we are not focusing on that, but it will take much more time to reach the technology from the FCSB level. Thank you.
Thank you, Dr. Beena. Yes,
If
Dr.
I can add just a short point. I think one of the greatest strengths of the community health worker model is that the community health worker actually comes from the community they're looking to serve. Oftentimes, even in primary healthcare teams, doctors typically tend to come from outside, often tend to be transitory as a workforce. I think I have seen the natural use of WhatsApp among community health workers. Sometimes when they make a home visit, they naturally take a photograph, and if they can share it with a nurse or share it with the doctor or share it with say someone who's available to talk, you get like two types of information. One, there is automatic geocoding of the home and the family where something is happening, like for example, I remember one of the community health workers taking the photographs of a child with SAM, severe acute malnutrition, and the home environment. Like there were four photographs. She just shared it with us. And then this can initiate follow up action. So I think there are various forms of technology and innovative use of technology that's already happening, driven by community health workers. One of the things I think we as a group must do is we must learn from them. There is too much sometimes emphasis on us training them, and sometimes the way transfer of knowledge happens is very inefficient and very hierarchical. I think there has to be humility among the leadership of public health systems and teams in also learning from the ground and learning from community health workers, including the way they use technology and what technologies are most useful to them and to the care of communities.
Hi. In my point of view, yes, technology play a huge role in that health security part. Two dimensions. One is service delivery, and the other part is capacity building. So in our setup, how we are using the technology in service delivery. One, we use the GPRS things to locate the houses and for a follow-up between that. Second, we use the technology when the community health workers visit to the house. They use WhatsApp or Viber, and with that, the doctor who is in the institution can communicate with the patients as well as the community health workers, WhatsApp and Viber. And second and the third, we have many health education videos that is that can be shown to the patient through the WhatsApp and Viber, or else that patient through the computer mobile phone they can go that. And then we use that we use artificial intelligence to screen something. So we use things called Alive Pro. That's 1D ECG. So we connect the mobile phone, and community health workers can easily to check the APL situation. So then we use that type of screening as well. At the same time, now we collect all our data in a cloud-based form called RedCap. So then when the data collectors the community health workers or data collectors, when they are collect the information, that will be in the cloud. So someone who can the cloud-based RedCap that help us to think and evaluate, and that is real-time data. So we plan to use that so data-driven researchers. So then these are the service delivery we use the technology. Capacity building, just through the Zoom technology, we people in this part of the world through our people who are in the Western world, mainly our teachers and diaspora. So there. Some people are really good in some aspects. So they try to develop the capacity building through the Zoom technology. So these are the currently these are the things we are using the technology in improving community health like that. And finally, we use the Hobo Collect, another platform is very user friendly. So we use Hobo Collect to give feedback from the beneficiaries from the community health workers. So luckily, because even the elders, they really very good in mobile technology because they experience in foreign countries. So they used to discuss with their children through this and Viber. So they're fairly good in information technology. So we can collect the feedback from the participants through Kobo Collect. So I feel that technology is very useful for us in implementing this program and ensure the.
Thank you, Dr. Kumari. With this, we come to the end of our webinar series for the World Health Day. And it was a great learning experience, right, from Dr. Beena, Dr. Kumaran, Dr. Jaleel, and Dr. RK. So, we started from how community health workers are appointed in the hilly areas and the plains in Nepal, and how trust deficit and use of them and data collectors often impact them. And then from Dr. Jalil, where he said about a new technology innovation model being developed at Islamabad with WHO also sharing the technical expertise, and Dr. Kumaran sharing how university settings, medical colleges, and the hospitals culminate their efforts to enhance the way primary care is being delivered. So thank you all for offering valuable insights from different countries within the Southeast Asian region, and definitely bring these lessons to the Wonka team as well, so that we can closely engage with each one of you going forward. Yeah. Thank you. And I would lastly deliver the vote of thanks. Firstly, I would like to thank the Dr. Sneha Pratap Kotiam. She has been the backbone for organizing this event. I would like to thank Dr. Pratyush Kumar for initiating this panel discussion. I would like to thank Prasanna School of Public Health for providing us with the facilities to organize this webinar. And I would like to thank all the panelists to have come on a long weekend. I understand today is a Friday, tomorrow and day after this, a weekend. Despite being that you have made your valuable time to this webinar, and I wish you a happy weekend forward. Thank you.
Thank you, everyone. Thank you.
Thank you so
Thank you very
much.
much.
Thank you very much.
Yeah.
Thank you. Thank you.
A
Wish you
very
all a happy
insightful
weekend
discussion
too.
in it.
Bye.
Yeah. Bye-bye.
Thank you.
Thank you. Good night.